So somebody requested that we talk about upbeat nystagmus. And nystagmus is rhythmic, which means you can play a drum to it if you follow the waveform of it. And in upbeat, as you know, we're naming for the fast phase, even though the slow phase is the pathologic phase. So the slow phase is a drift of the fovea off of the target. It requires a corrective saccade upward, which is going to generate upbeat nystagmus. So upbeat is fast phase up. It's a little bit different than downbeat nystagmus, which normally increases on lateral gaze. And in fact, upbeat can convert to downbeat nystagmus in convergence. It doesn't really tell you where the problem is, even though traditionally the localization is vermis from a central vestibular nystagmus. And so if we have a pure upbeat or a pure downbeat or a pure rotary, that normally means it's central vestibular, because the peripheral vestibular system produces mixed waveforms, combinations of horizontal, rotary, and vertical. If it's strictly upbeat, it's central. And it can be anywhere in the brainstem. And typically it's going to be at the pons, either the pons to the mesencephalon or the pons ponto to the medulla. So the pontomedullary and pontomesencephalic junction. And that means it could be the midbrain, the pons, or the medulla, which is pretty much the entire brainstem. And if you add in the vermis, that means the lesion is posterior fossa somewhere. It doesn't tell you what the cause is. It just tells you where the problem is. We know it's a central vestibulopathy. We know we have to image the posterior fossa, and that means having an MRI. It doesn't tell us what the cause is, and so if the MRI is negative, you have to be looking for a differential diagnosis that includes things we can't see on MRI. So the things we can see on MRI are tumor, stroke, demyelination, masses, hemorrhages. We can see structural lesions on MR. But what we can't see on MRI are vitamins. And in the acute phase, if someone comes in with upbeat nystagmus and they have no cause and an MRI is negative, you should be thinking about Wernicke encephalopathy and giving the thiamine. So we can't see the vitamins. We also can't see antibodies, and so paraneoplastic disease, autoantibodies, inflammatory disease, none of that can be seen, and so you're going to have to do a lumbar puncture if the MRI scan is negative, and you have to test them for the autoimmune antibodies that are going to be present. So the things we can't see are, we can't see metabolic things, so vitamins, antibodies. Sometimes we can't see subclinical ischemia. We can't see toxins, so you got to think about all the drugs, most commonly anti-epileptics, but any centrally acting drug, antipsychotics, a whole host of sedatives and other drugs can cause nystagmus, including upbeat nystagmus. So when you see upbeat, fast phase up, thinking about brainstem and cerebellar vermis, it's a central vestibular nystagmus. Do an MRI scan. If it's negative, give the thiamine in the emergent setting, in the acute setting, test for the antibodies, do a spinal tap.